It's October 1st, 2021. This is the RheumNow podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. You know, it's great to be a rheumatologist. We've got a lot of tools. We got a lot of challenging patients. There seems to be a lot of education out there, but boy, it's getting harder and harder. I mean, you have to be a jack of all trades. Today's report, for instance, you've got to be good at cardiovascular disease, osteoporosis, vaccination, inflammatory bowel disease. I mean, it just doesn't end. But first, let's begin with this report. Pediatric Rheumatology talks about the risk of developing juvenile idiopathic arthritis after receiving antibiotics. Not after having infections, after receiving antibiotics. You know, we reported about this, I think, maybe a year or two ago. It's been out there that antibiotic use may predispose kids to developing JIA. This is a population-based study from Sweden where they looked at birth records and antibiotic exposure both in utero in the first few years of life, and they found a higher risk of developing JIA, and it seemed to be across the board. The only interesting thing that sort of distinguished the subtypes of JIA was that systemic JIA was associated with a greater use of in utero exposure to antibiotics. Which antibiotics, you say? Well, most of these were penicillins, so no particular antibiotics seemed to jump out. All the other subtypes seem to have occurred with antibiotic exposure after birth. And again, the interesting thing on this particular study, not seen in other studies, was that it wasn't infections per se, but the antibiotics. More antibiotics, the greater the risk. Now, again, you can make your own conclusions here as to why this occurs. Is this a microbiome change? Is this a maturational effect of antibiotics? Could they be anti-inflammatory and immunomodulating in themselves on, you know, the thymus and its development and what's going on with the immune system in a young individual? Again, it's all conjecture, and this is epidemiologic data. It's nonetheless interesting. I mean, it's supposed to temper the overuse of antibiotics. Good luck with that. Another real interesting report actually comes from the National Danish Patient Registry, a report that just appeared last week from a meeting called the European Society of Diabetes, I think, EASD meeting, where I think a novel report, high numbers showing that exposure to bisphosphonates was related to a reduced risk of developing future type 2 diabetes. In this study, they had 160,000 type 2 diabetics and 500,000 or so controls without diabetes, and they showed that alendronate was associated with about a 35% reduction in the risk of developing diabetes, type 2 diabetes. If you were on alendronate for more than 8 years, it went down to more than 50% reduction. How does this happen? It's the magic of epidemiology and p-value fishing. I don't know. The authors didn't offer one. Of course, it's just an abstract from the meeting. If you research the subject, maybe there's a role for bone-derived osteokines or cytokines from bone that could influence glucose metabolism. It doesn't seem to be a differential effect of bisphosphonates on diabetics versus non-diabetics. It does seem that diabetics may have worse disease when they have osteoporosis. Other than that, I find this interesting. So, you know, BEST is a study that keeps on giving. Tom Huizenga and colleagues have another interesting report coming from BEST. It says something that supports what I've always said, which is if you're worried about RA flaring in the future, I always say it's going to flare in the way it began. The joints that were involved in the beginning are going to be the joints that are involved in the end. And that's actually proven in this 508 BEST study, as you know, a 4-treatment cohort study, treat to target. We're not going to get into the results, but they showed that your baseline joint involvement, your baseline swollen joints, really predicted future swelling and flares in those same joints. Now, yes, other joints could occur, but if you had it involved at baseline, you had almost a 2 to 3-fold higher risk of getting it later on. Way to go, Tom, and the best investigators. Scandinavian Journal of Rheumatology does a really interesting study clustering almost 1,000 RA patients into different types. And they did their clustering using agglomerative hierarchical clustering. Agglomerative hierarchical clustering. I think that's been outlawed as a form of torture at Guantanamo. I'm not sure. Or it could be the methodology that they use that I don't understand. Nonetheless, they came up with the bottom line is that the highest healthcare costs were associated with disease activity and comorbidity. I think we should underscore that comorbidity factor here. But they did find 4 cohorts. The biggest cohort, over 500, or more than half their patients, were young RA patients with low cost and low activity. That we're probably not paying enough attention to that subset. The next biggest cost, a few hundred patients with chronic pain, disability, and fatigue. The third cohort were a smaller cohort, high cost, high disease activity, less pain, interestingly. And the smallest cohort were those with comorbidities with an extreme amount of cost associated with their care. So even though comorbidities is the lowest frequency cohort, they come with a big, cost of care, dollar, tag to it. So again, I think this is an interesting analysis and something we might pay attention to if we take care of RA patients. The Scandinavians also came up with a very interesting, this is a Finnish study that looked at the risk of native joint infections. This would be prosthetic joint infections, this is septic arthritis following post-arthroscopic procedures. Now, a longitudinal study, again from Iceland, looked at a fairly large cohort and showed that post-arthroscopically there was an increase in iatrogenic native joint infections. Now, the numbers here are really low. So the overall risk of a native joint infection was 0.17%. 17 per thousand, goes up to 24 per thousand after knee arthroscopy. So it does go up, and one of our colleagues, Rahul Patel, on social media commented, why are they even reporting this? This shouldn't be happening if they're having common precautions that one takes. And he's right. The numbers here are very low. The thing that he did show, that the report did show, was that the risk of these native joint infections has risen threefold in the last 20 years. And I think that's worth noting. So talking about steroid injections and what may happen, a case control study looked at the risk of intra-articular steroids and showed an increased risk of developing rapidly destructive hip disease, RDHD. Don't use that abbreviation, but they did in their report. The hazard ratio associated with steroid injections was almost a 9-fold increased risk. That's something to pay attention to. I think this is something that we should worry about. We do a lot of steroid injections. Hip steroid injections are often given to people who are at the end of their rope. They're on their way to surgery. You want to avoid surgery. You can't do surgery at this time point. So, this is there's a risk to be had here if you're going to do an intra-articular steroid. Maybe that it could accelerate these findings. So something we don't talk a lot about here in the United States is biosimilars. Why? Because only 60% of them have made it to market. Currently, there are 31 FDA-approved biosimilars, but yes, 40% have not yet hit the market because of legal wranglings, financial arrangements, God knows what else. If you want to understand biosimilars in the United States, follow the money, and that would be the answer. The rate of drug growth in the United States was 6.1%. This is actual spending on drugs from 2015 to 19. However, biologic spending was more than double that, 14.6%. And as you might well imagine, biologics account for almost half the cost of U.S. drug spending currently. Now, how much are we spending on biologics? I don't know, but a nice report this week said that generics and biosimilars had a record $338 billion in sales in 2020. When I kind of was scratching around inside that report, it looked like it was less than $100 billion from biosimilars, and that might grow in the future when we get more biosimilars on the market. I think a lot of the big things that were in the news this week is all the vaccine talk. It won't stop. Patients are wondering about the booster and when to get it first. I put this out because I think it's really important, and that is, can you get the influenza vaccine, which we should be getting now, and should be done before the end of October, can you get it with the COVID vaccine? And the CDC says yes. I mean, you can give multiple vaccines together. Think about Army recruits. They go in, they get in line, they get shot with a pneumatic gun that's got 25 vaccines in one shot. And boom, 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 they go down the line. I know I did this in a third world country once. And you can deliver multiple vaccines at the same time. So yes, you can give influenza and COVID vaccines together. They recommend that you basically follow all the precautions for each. The CDC reminds us the flu vaccine, influenza vaccine should be delivered by the end of October. It's really important right now because you don't want to be confusing this fourth surge of COVID with the onset of influenza, which could occur in the next 4 months. I'll remind you, in 2020, the rates of influenza went down 98% due to, where's my mask? Here's my mask. In Fauci we trust. Physical distancing and washing your hands. Mask up, back up, wash up is what I say. MMWR has come out and said that you can get the third dose if you are over 65 and if you are immunosuppressed or taking immunosuppressants. Their recent safety study that was published says that the side effect rates are the same with the third vaccine as that seen with the second dose. So there's no new increase in adverse events when one goes and gets a booster. Strong wording came from the CDC just yesterday. The CDC strongly advising that the COVID vaccination be given to women who are pregnant, either before or during their pregnancy. They note very low rates, especially among certain ethnic groups. While the highest rates are like 45% in Asians, Hispanics and African Americans are like 20% and less. Overall, it's in the 20% that pregnant women who've been vaccinated. And as of September 27th, 125,000 confirmed COVID cases and a total of, 22,000 hospitalized and 161 deaths, all preventable. So go ahead, and we've talked about this in the last 2 weeks about what you advise your pregnant women who are going to consider the vaccine. So when talking about pregnancy, I think it's a lot like talking about the movie The Godfather. You know, Clemenza, he says, leave the gun, take the cannoli. In the case of pregnancy, leave the Tylenol, take the aspirin. What's he talking about? I haven't lost my mind. I'm still on script. U.S. Preventative Services Task Force, USPSTF, has recommended that women who are at risk for preeclampsia should be taking a daily aspirin regimen at the end of the first trimester. So that's after the first trimester. It says at the end of the first trimester. So look up that citation. This is relevant to our patients, especially lupus patients. I think that it might be advisable for such patients, even if they don't have a history of antiphospholipid syndrome. The other pregnancy came out, a report this week that was, I think, very controversial, very confusing, was a big report that got a lot of play at the end of last week, last Friday, early this week, about Tylenol, acetaminophen, paracetamol being potentially hazardous in pregnancy. I thought this was crazy, but this comes from an endocrine journal, which I found interesting. 91 scientists, clinicians, and public health professionals alarmed the world last week when they suggested that acetaminophen during pregnancy may have hazardous effects on fetal development. In their preamble, they talked about what is out there, that there's increasing rates of developmental disability in our society right now. Forget about the drugs, just developmental disability. They say that there's also an increasing rate of neurological, urogenital, and reproductive disorders. They then proceed to go through the literature using epidemiologic and animal data, experimental data, to say that there could be links here that we should be paying attention to. They say that, no regulatory agency has given this the time of day, and none of the societies are talking about it, and they want to create a big splash and want the regulators and societies to talk about it. Well, that may be a likely result. But I can tell you, when you look at the data, I think it's a lot of nonsense based on conjecture and, a lot of animal data. I'm not going to stop my pregnant patients who are having a lot of pain, back pain, all kinds of muscle and joint pain especially in the third trimester, acetaminophen is recommended by many societies and by regulators and by guidelines for the management of pain and discomfort and fever in pregnant women. I wouldn't change that practice based on this report. There were several reports this week about heart and rheumatoid arthritis. One actually saying there's an increased risk of mortality following heart bypass, a 50% increased risk in RA patients should they undergo bypass, and a higher risk of MI following bypass. That's about a 60% increased risk. This is finished data, retrospective data, comparing almost 400 patients to almost 8,000 non-RA patients. It's kind of convincing evidence, and we do worry about cardiac effects in our patients. So clearly an RA patient who needs a cabbage needs a cabbage. But there are going to be consequences to the cabbage that may be a little bit higher in a patient who has rheumatoid arthritis. Another report appears in Arthritis and Rheumatology saying that early diastolic dysfunction in premenopausal RA patients. This is a study that interestingly finds evidence of diastolic dysfunction before the patient has any symptoms, before there's any evidence of overt heart failure. They studied 170 patients overall with 2D echoes. About 70 of them had RA, then others were non-RA controls. While RA patients had an equal and unchanged or sort of an expected amount of ejection fraction being greater than 50%, there was more echo evidence of diastolic dysfunction in the RA patients, and it was felt that this was premature. Diastolic dysfunction 47% versus 26% in the controls, and that was highly significant. Again, who's at greater risk? Women 30 to 49 years old had a threefold higher risk, and it was higher in women who had high CRP levels. So again, this is another one of those things we have to worry about in our RA patients. I thought this was an interesting report because it's going to impact one of my questions later on. 108 patients with autoimmune cytopenias. That includes autoimmune hemolytic anemia, ITP, TTP, etc., who were given COVID vaccination, showed low rates of post-vaccination flares. So they showed like a 7% increase in AIHA and ITP manifestations. Same again, was seen with other autoimmune hematologic disease. I'm going to talk about this in one of the cases we're going to talk about from you, the audience. Lastly, there's an interesting study called Global Secure that says that the safety of drugs that they use does not seem to impact COVID outcomes. So IBD drugs overall, and that includes and biologics. So this includes mesalamine, sulfasalazine, azathioprine, 6-MP, methotrexate, combination therapies and biologic therapies, including the TNF inhibitors, IL-12/23, IL-23, and integrin targeting therapies, all do not seem to have any impact on rates of severe COVID outcomes. I thought that was kind of in line with what we're seeing in our inflammatory arthritis patients. If you're interested in IBD, there's a really good review of new drugs for IBD in the current issue of the little-known New England Journal of Medicine. This week, we've got 3 cases and questions from you, the audience. We'd love to hear from you. If you've got an interesting case or question, you can click on that on the website or on the email and record it, and we'll play you and your voice back, or you can email me. I've got 2 emails. Dr. Hytham Elisser, rheumatologist from New Zealand, wants to know, what do you tell your patients who are taking zoledronic acid and they're also on steroids and they're about to have dental surgery in the next few months? I tell them, don't stop. As you know, the dentists are all wigged out about this. The evidence is that those who get more osteonecrosis of the jaw are those who've had, who are on bisphosphonates and have had either those events in the past. But the bottom line is, there are guidelines on for dentists from dental societies that say that whether it's IV or oral, the risk of bony osteonecrosis appears to be incredibly low. so much so that it should not dictate changes in therapy, the rates being approximately 0.7 cases per 100,000 patient years. Yes, IV patients might get osteonecrosis of the jaw within a few months earlier than those who are on oral, who need to be on it many years more. But again, the bottom line is you probably shouldn't stop it, and that really is what I think drives the decision for me, meaning that how much does a patient really need to be on the bisphosphonate? Is a patient due for a drug holiday? Is a patient, in that gray zone between, almost normal and mild osteopenia, where the benefits are not as great as they would be for someone who's got, really worrisome numbers, meaning a fracture rate greater than 10%, or DEXA values at -4 or even worse. Those stopping the drug is going to be far more hazardous than continuing it and incurring some really minuscule risk associated with the bisphosphonate. Holly Bastian sends me a question. Thank you, Holly. She has a woman with cutaneous shingles 3 times in the last 3 months taking adalimumab. While she has not personally witnessed any of these episodes of shingles, the patient's description seems credible. She's thinking of giving the Shingrix vaccine. She wants to know what to do about biologic therapy, and do you stop it before vaccination, and for how long, or should the patient be on Valtrex prophylactically? Number one, no to Valtrex prophylactically. I think first that you really want repeat episodes of shingles to be diagnosed by you, if you're comfortable making that diagnosis, or a dermatologist. I've got lots of patients, as do you, who say they have shingles and they do not. Okay? So it's got to meet the definition of shingles. Second, 3 episodes of shingles in the last 3 months merits an infectious disease consultation. 1, to deal with some of the questions that you raise, and 2, to, again, reaffirm the diagnosis. The patient should have received Shingrix. I'm assuming the patient is old enough to get Shingrix, but someone with recurrent shingles infections probably should pay the $330 out of their pocket to get the vaccination. There are no clear guidelines on what to do with the biologic, or in this case, adalimumab, or if the patient was already on, for instance, a JAK inhibitor. I tend not to stop adalimumab and TNF inhibitors when I'm going to give the Shingrix. The same can be said even for JAK inhibitors, although there was a report from last year's ACR meeting, abstract 1997, Kalmark and colleagues, actually Kevin Winthrop talked about it also in one of his reports. 40 RA patients on tofacitinib showed that about 8 of the 40 did not have a good response to the vaccine, and that being the Shingrix vaccine. So, and that kind of goes along with what we've seen during COVID and recommendations during COVID. You probably should be stopping certain drugs when you're going to take the COVID vaccine, or when you get the Shingrix vaccine. And that does include JAK inhibitors, does not include TNF inhibitors. Yes, methotrexate, yes, JAKs, yes, abatacept. These are ACR guidelines. So I probably would stop. You should know, again, there's no guidelines on this that are firm, but when I surveyed 1,000 rheumatologists about what do you do when someone gets Shingrix and they're on a biologic, like 90% of you stop the biologic. How long? No one knows. If I had to stop because someone got shingles, I would stop it until they develop crusted over lesions, and I certainly wouldn't stop for as long as 6 months, probably a lot less than that. But I might hold a JAK inhibitor. I personally would not hold adalimumab. I'm waiting for guidelines to tell me I'm wrong. So we have one more, and this is going to be a Talkback voice recording. This is from Dr. Mark Niemer. Mark asked a question. I'm sorry, it's not working right now. He asked a question about one of his patients with, I can't remember if the patient had myositis or not, but the patient received the COVID vaccine and developed very high the patient had inflammatory myositis, received the COVID-19 vaccine. He didn't say which one, and developed very high elevations. I want to say 8,000 CPK elevations following the vaccination. What's he to do? Is this related to the vaccine? Is this, the disease? It certainly could be the disease, but if it has a temporal relationship to the vaccine, I would be suspicious. There is a lot of literature right now. I found 2 online where, yes, myalgias are common, but there are many cases of autoimmune disease. One of the more common autoimmune diseases out there is pericarditis and myocarditis. It wouldn't make, and I haven't found many reports of overt myositis, but there's a lot of ANA positivity that happens as a result of COVID. Not as a result of COVID vaccination, but as a result of COVID vaccination, there are reports of pericarditis, myocarditis, and other inflammatory and autoimmune features that have been seen. I've seen RA patients get worse. Again, these happen usually within 2 or 3 days of the vaccination. The symptoms last, anywhere from 1 to 3 weeks and tend to resolve. I think your plan of attack would be to support the patient. It wouldn't hurt to give a burst of steroids unless there was a contraindication to get them back under control. I would assume that the CPK elevation probably was without symptoms, because usually flares like this, the enzymatic flares usually precede the clinical flare, so maybe a burst of steroids before the clinical flare might make sense. Anyway, that's it for this week on the podcast. You can go to the website, check out these citations and more. Tune in next week. As we said before, mask up, back up, wash up. Now you can listen up. Take care.